And it's great to have you all here. I see we've got about 60 people on. This is a new format that we're trying out. It's really going to be determined by what you guys need and what we can and what topics we do and how long you want to do these things for. So just to introduce myself, my name is David Bishop. I work mainly at Edendale Hospital, but also at Gray's Hospital in Pietermaritzburg. And I'm the district anaesthetist for Mgungu Ndlovu. So most of my anesthetic training has been at Edendale. I did work at Imseleni Hospital as part of my, well, in about 2004. And I've worked a lot at Zetoleli Hospital and in conjunction with that hospital. And I've got quite a strong district or rural background in that it's what I lean to as an anaesthetist. I also work with UKZN. I'm an associate professor in the Department of Anaesthetics, and I'm employed by the Department of Health. And in addition to that, I work with the confidential inquiry into maternal deaths. So obstetric anaesthesia in particular is a passion of mine, and it's something that I want to support as much as I can. My official title is that I'm a district clinical specialist anaesthetist. Now, the DCST teams are supposed to be made up of a family medicine doctor, an anaesthetist, a pediatrician, an obstetrician, nurses, and doctors. One of the problems that we have in South Africa is that at last count, I was one of 2 district clinical specialist anaesthetists, and there are 52 teams across the country. And these teams have done really good work, but mainly in the area using the family physicians and the pediatricians and the obstetricians, but not so much the anaesthetists. There hasn't been so much buy-in from the anaesthetic side, or these posts haven't been available, or there are all sorts of reasons. But what it means is that in the district hospitals, you don't have a DCST anaesthetist that you can phone and get information from. And so what I'm trying to do with this is firstly tell you that I'm available to anyone who wants to chat to me or ask me questions or get information from me. And secondly, we need to look at new models that get anaesthetic information and education out there. So we are trying this method. And even though my area is Mgungu Ndlovu, I'm seeing this as a KZN provincial initiative, and I'm actually very happy to move this out. I know we've got people from the Eastern Cape here. I've got no boundaries in terms of who I want to support. This has got UKZN support and it's got DOH support, and we'll see how it goes. So the object of these meetings, firstly, is to make connection. I really want to be used as a resource by the district hospitals. I think we need to aim to improve the way we do anesthetics, and I'm not always going to introduce with how we're doing, but I am going to today talk a little bit about how anesthetics is doing in South Africa. I'm hoping we can develop interest in anesthetic topics, which will stimulate reading and growth, particularly if one person in each district hospital is taking an interest in anesthetics, and then I can support that person who then cascades information down. I want to layer knowledge. So we're going to start fairly simple today, but there's going to be a fairly long time at the end, and I'm going to stay online for as long as you need me. And we'll cover all the things that I perhaps didn't answer today, because I didn't want to get into too much depth on some of the issues. And finally, I'm going to try and keep this practical and pragmatic. The term that I use a lot is context sensitive. I'm really going to try and keep this relevant to what you're doing in a district hospital, rather than getting into some academic material that we perhaps don't need in that setting. So, surgical conditions, this is an amazing statistic. They kill more people each year than HIV, AIDS, malaria, and TB combined. So it's a huge problem in low and middle income countries. Now, we obviously pour money into the other things, but we put less money into the surgical problems. So we need to look at how we can do this better. 15% of all pregnancies will require emergency obstetric care, and that includes safe surgery. I'm just going to mute everyone again. And up to 90% of maternal deaths could be prevented with timely detection and availability of obstetric surgical care. So we're always going to be focusing on obstetric care, but there are other things we need to look at as well. But this is an area where we really need to do better. Now, you may have heard of the concept of a bellwether. In medieval times, you put a bell around a castrated ram's neck, that ram was called the wether. So it was a bellwether, and he would lead the flock. And then you'd be able to find your sheep in the mist. And it's come to mean something that leads or indicates a trend. And the bellwether procedures are what the district hospitals are supposed to be doing. And district hospitals are supposed to be offering emergency cesarean section. They're supposed to be able to do an emergency laparotomy, and that would be for something like an ectopic pregnancy or an appendix. And they're supposed to do operative fixation of a long bone fracture, of an open long bone fracture. Those are the procedures that we're supposed to be doing in district hospitals. But if you look at what we're actually doing, this is for KZN, you'll see here that the dark blue lines are the cesarean sections. We're doing Seizures, but we're not doing laparotomies and open reductions of fractures. And the reason for this is probably that as we've progressed over the years from doing GAs for Seizures to spinals for Seizures, we've become more reluctant to do GAs in this setting. And then there's some other reasons as well, which I'll come to. But what it means is we're doing a lot of Seizures and not a lot of the other things. And part of what we're going to be trying to do with this program is talk about how to get that whole package of care available. Now, we're one of the few countries in Africa. In fact, we're the only country in Africa that does a confidential inquiry into maternal deaths. So this is 2011 to 2013. And there was a report that came out then that said that 50% of anesthetic deaths die under spinal anesthesia due to untreated spinal hypertension. In 7% of those deaths, there was a solo Caesar. And a solo Caesar means there was one doctor in the room. Doctor put the spinal in, doctor did the Caesar, while someone else presumably watched over the anesthetic that wasn't a doctor. And that's obviously not something we condone, but it still is happening. And certainly in my career, I've done solo Caesars. And then these deaths are happening at district hospitals. And really what should happen is that the deaths should concentrate in the tertiary hospitals where the complex cases are. And the district hospitals should be seeing fewer deaths, but we're not. We're seeing more deaths than we should. And this is obviously very worrying because if more than 50% of anesthetic deaths are from untreated spinal hypotension, we know how to treat that. That is a very, very treatable problem. So it is a marker, if you will, for the standard of care and something that we can improve. This is a very interesting slide as well. This shows the yellow bars are the rising cesarean sections. This just goes up to 2013, but that line has just kept going up. We are doing more and more cesarean sections, yet we are not passing more DAs and we are not passing more specialist anaesthetists. So anesthetic skills have remained static, or the number of people that are able to administer an anesthetic has remained static, and yet the demand has increased. So what we really need to do is start capacitating more people to give anesthesia. And this is especially true in the district hospitals, because we all know where these anaesthetists are. They're sitting in the city centres, and they don't hang out in the district hospitals. And so that's a big if you look at the confidential inquiry for 2017 to 2019, so this is the most recent report, the anaesthetists looked at 921 deaths. That's over 3 years. 7% of them were direct anesthetic deaths. That's a higher number than we've ever seen. But for the first time, we started reporting on another statistic, and that is how many of the deaths had an anesthetic contribution. And that was a further 15%. And what this means is that if somebody dies of postpartum hemorrhage on table, and the anesthetic that was given either contributed in some manner, there was either action or inaction that contributed significantly to the death, then we marked it down as an indirect anesthetic death. And so what you're seeing here is that about 1 in 5 maternal deaths that occur in theatre is an anesthetic contribution. And that's very, very worrying. And finally, before I get into the meat of the spinal anesthetic talk, just one more point that I think is very relevant in the district hospitals. This came out of a study that we did called ASOS OBS. It where we looked at mothers that are having surgery in Africa. It was a huge study. And we showed that there was a 3 times increased incidence of peripartum complications after Caesar, 3 times increased in our setting compared to a setting like the USA. But there's a 50 times increased maternal mortality. And what that means is that when our patients complicate, we don't rescue them. We're doing reasonably well until they complicate. And as soon as they complicate, then that's when we fall down. And so we need to learn to manage the complications that arise around cesarean section. And the reasons for these problems are obvious. There's a skill deficit. But if you look at our setting, 1/3 no electricity, 3/4 don't have reliable pulse oximetry, 1/4 no oxygen, and 1/2 no post-operative care in low middle income countries. And if you're working in the district hospitals, I know that all of you have at some stage faced these problems. You've done operations in the dark, electricity gone. Could we just keep muted? I'll see if I can mute everyone.
Come on.
I can't find where to mute everyone else. Please just mute if you can. All right, so what we're going to talk about in terms of spinal anesthesia is a few basic points. The first is that we need to prepare as well as you can before you start. You need to think before you put in the spinal. We need to do the basics right. We need to expect common complications, and I'm going to go through just a few. We need to start valuing the recovery period. And we need to remember that we can phone a friend. So I'm going to go through these 6 areas and discuss basic points within each. And at the end, we'll come to a protracted question and answer sessions. Now, mothers are dying under spinal anesthetic because we put spinals inappropriately into the wrong patients. We don't manage the complications quickly or well enough. And then bad things happen. Patients start to bleed and they're under spinal anesthetic, and we can't cope with what happens with under spinal. So the first point in terms of preparing is to know your theatre. Now, in a district hospital, this is very important that at least one of you really knows your theatre, knows where everything is checking that it's stocked. And this is just a discipline that somebody has to take on. Now, if you look at the ESMO-E document, there's actually a very nice essential equipment list for anesthesia within that document, and we need to use that document. I'm not going to go through all of it, but what I would advise that you do is these documents that I'm putting up, which I'm very happy to distribute, you should keep these in your theatres, display them, laminate them and display them. And somebody needs to go through this and just check that everything's there once a week. And this is normally a nursing job, but having someone in anesthesia that checks up on this is very important. When I walk into a theatre that I know is well checked, there are 3 things I always look for, no matter what's the situation. I check that I have an ambu bag, I check that I have oxygen somewhere, and I check that the suction's working. If you've got those 3 things in place, you can rescue most situations. But if you've ever had a patient vomit on you and the suction's not working, there is nothing you can do if that's not in place. So have your detailed check, and then check at least these 3 things are in place. Even if you've forgotten to check for a circuit on your anesthetic machine, you can get by with an ambu bag and oxygen. But you can't get by if you don't have one of these 3 things. So get into those habits. Always check those 3 things are present. And I know this seems obvious, but you must examine the patient. And just ask yourself, wherever you're sitting, in whichever hospital you are, if you've ever done an anesthetic in the district hospitals where you've examined the patient as an obstetric patient, so that is a sub-umbilical examination, you've assessed the need for Caesar, and you've put in the spinal and you haven't put your stethoscope on the heart, or you haven't actually thought, is this a difficult airway? The 3 things I think you must do every single time before you put the spinal in is you must have put the stethoscope on the heart. You don't want to miss a loud murmur. You want to think about every single airway, because if you have to convert, you don't want to suddenly think, oh, wait, this is a difficult airway. I wish I had a LMA or a supraglottic airway device. And I also think that you should look for pallor. You should have a ward HB before you're going in at least, but those 3 things you should do every single time, and just get into the habit of examining your patient before you put the spinal in. We've got so many stories of people who think, I wish I had done this. We've got, I know of one case where somebody put the spinal in, and then when she was converting to general anesthetic, she noticed the patient had a wired jaw after she'd given the muscle relaxant. And because she was so experienced, she was able to intubate the patient. These are not things you want to find out mid-operation. And finally, again, this seems obvious, but use your monitors. For some reason, we've got ECG available, we've got the SATS probe available and blood pressure cuffs, and yet not all the monitors are always on the patients. If I can encourage you, please, to put your ECG monitors on. The reason for that is when blood pressure drops, either under spinal or GA, the SATS probe, which is giving you your pulse rate, is the first thing that goes. And you need a heart rate, because a lot of what we do when we manage complications is dependent on the heart rate of the patient. And so if you haven't kept the ECG lead on, you lose that. And it's a very valuable monitor. I know that in my first few months of district hospital anesthesia, I didn't use the ECG monitor, and I had a diploma in anesthetics. I have no idea why I didn't do that. And it took a district hospital doctor to point that out to me. So these are very, very basic things. But the cases that we review when mothers die on table, it's not the complex stuff we're not getting. It's the simple stuff that we're not doing well. The next thing I want you to do is to think before you put the spinal in. Just pause before you put the spinal in. What is the indication? The indication will often tell you you're doing the wrong thing. If the indication is bleeding, or should we really be doing this under spinal anesthetic? If the indication is a placenta previa and you've had to do this in the district hospital, should you be doing this under spinal? The second thing is, what is the heart rate? Have a look at the heart rate. Now, if the heart rate's under 100 and everything else is good, then carry on. If the heart rate's between 100 and 120, stop and think at least. There's a significant chance that patient is going to be hypotensive if you put the spinal in. Heart rates in that range of 100 to 120 that have a high blood pressure. Could be anxiety, it could be pain, and you're probably all right. But when the blood pressure is borderline with those sorts of heart rates, when you've got a systolic of 100 and a heart rate of 105, be very, very wary and stop and think, because once you put the spinal in, you can't take it out. If the heart rate's over 120, you really need to know what you're doing. And so we sometimes do put spinals into those patients, but to my mind, if that is consistently over 120, phone a friend, phone a senior, find out if you really are on the right track. And if it's over 140, don't ever put a spinal in. There's almost no circumstances where I'll put a spinal in when the heart rate is that high. Ask yourself if the patient looks sick. I know this is a silly thing, but sometimes patients just give you that feeling, and take that seriously. Ask yourself if things are likely to go wrong. And the point that I'm making here is that sometimes patients that are very well getting a spinal, they were predictably going to get into trouble. An example is a previous Caesar ×3 that you bring into theatre with a surgeon who's just starting. That patient's likely to bleed, things are likely to go wrong. And when you've got a well patient in front of you, where things are highly likely to go wrong, you've got time. So you can think about your anesthetic technique, you can think about whether you're doing the patient in the right setting, should the patient even be at district. But once the spinal's in and you've started, you're committed. So think about those possibilities. One of the nice things on your checklists to use is risk factors for PPH. And when you're starting to stack risk factors, grand multips, previous Caesars, low HBs, you can start to think maybe the spinal is not the right thing to put in. And then are there obvious contraindications? And I've avoided putting up big lists of contraindications. These are easily available. But if your patient's coagulopathic or septic, obviously these are not patients to put the spinal in. So just have a pause and think, should I really be putting in the spinal? It's the default for many of us. It's the thing that we can do. So we tend to just default to it. And then do the basics right. Most of the problems that we see are not because people are haven't read enough. It's because the basics aren't being done right. And again, there are ESMO-E guidelines for all of these things, and these are really worth looking at. Again, they've got lots of good stuff in them. This is just a guide to appropriate levels of care. And the point that I want to make from this document is that there should be somebody who has expertise in anesthesia. And in KZN, there's now a circular which mandates the appointment of a lead anaesthetist per district hospital. And that lead anaesthetist is going to be our contact point, who we send literature to, who we prioritize for in-reach training. And we want each district hospital to have somebody who feels like they are reasonably confident and can do a general anesthetic. And then that person is your go-to person in the district hospital when you've got a difficult anesthetic. But difficult anesthetists are common. So try and have somebody in the hospital that is going to take responsibility and develop an interest. And to my mind, district hospitals work best when you've got these people with interests in areas. So there's somebody who's leading pediatrics, and there's somebody who's got an interest in HIV. Find someone with an interest in anesthesia and let that person lead the way. You need to be able to do a GA and a spinal. And unfortunately, you can't put a spinal into an obstetric patient if you can't convert to GA. But we also realize that not everybody in the hospital can necessarily be at that level. So what we're advising is that at least somebody must be on the grounds that can do a GA. So if you need to convert, you're just bagging and getting that person into the room. Because it's probably too much of a reach that everyone is confident with the GA, but somebody must be confident. And if your hospital has no one that can do a GA, then you need to act on that. And there are lots of ways to do that, which we can talk about at the end. You need an appropriate team. And again here, you need to have at least 2 doctors in the room. And both of those doctors can't be scrubbed. So one of them has to be free to do the anesthetic and one of them doing the surgery. We realize that there's often problems with people quoting the scope of practice, but you need to get the right team in the room, and it's very important for when things go wrong. And then finally, on this document, it lists which patients should not be done in the district hospital. And I'm aware that you don't always have a referral center that's trying to take every patient, but it is worth thinking about. And some of the things that are supposed to, I think we often think there is no option for referral, and we end up doing inappropriate cases. And even if you've ended up doing them, it's at least a system that we need to fix. And there are lots of ways we can approach that. Here are some of the things that are supposed to be referred. Interestingly enough, ruptured ectopics do not get referred. So one of the goals we have to get to is that all ruptured ectopics are done at base. There's the recent confidential inquiry showed that 38% of ruptured ectopics get an anesthetic, which means almost 2/3 we didn't try to institute definitive management, which is controlling the bleeding. Now, I know these cases are scary, but that's what you have to aim at. You have to be able to do a ruptured ectopic pregnancy. And myself and Simon Leroux wrote an article on this in the South African Family Practice, where we detailed what we think is the simplest way to get an ectopic pregnancy done. And if you haven't read that, have a look at it. And that's really what your service has to aim at. You're not supposed to do BMIs of more than 40 or the weight of more than 120 kilograms. These are supposed to be referred. Again, I know maybe some of you are chuckling, but that's what the suggestion is, because these patients complicate. The odds ratios for just about everything are about 3 times higher. And on there is difficult airways. When you've got a very difficult airway and everything else looks fine, if the patient's an elective, you should move that patient, because you are not equipped to deal with difficult airways in a district hospital. So these are the sorts of things where your examination might help you move the patient out. And if you find an anesthetic department and you say, I've got an elective Caesar and a difficult airway, the anaesthetist will accept that patient. Well, they should. Within that ESMO-E document is how to draw up all the drugs. This is the Maritzburg update. These are the sorts of things that you laminate and stick on your wall, because you cannot remember all these doses if you're not doing this regularly. So get these things printed out and stuck up in theatre. And then this is the meat of what we should be doing for cesarean section and a spinal anesthetic. And I'm just going to pull up a few points from this document that I think are absolutely key in managing spinal anesthesia. The first is that before you put the spinal in, have a think about the fluid status. In general, cesarean section patients are a little bit behind in fluid. They're either electives and haven't been fed for 14 hours, or they're emergency patients and they haven't had the drip and they haven't been allowed to drink or eat. So as a general rule, giving the patient a little bit of fluid before you start is probably warranted. The one exception to that is the hypertensive disorders. Again, those are supposed to be referred, but I know that we do them in district hospitals. There you're probably looking at fluid restriction, but everybody else is probably a little bit behind. And it is okay to give the patient fluid in theatre, but it is not okay to put a spinal into a patient who's behind in fluid. Their blood pressures will disappear. The second thing is good IVI access. The time to get this right is before you put the spinal in. So don't think, oh, I've got a partially running pink Gelco. You want an 18 gauge that's working well, and the time to sort this out is before you start. ESMO advises you give a preload of 500 mils. This is to negate that the fact that probably patients are coming a bit dry. So while you're thinking, run in half a liter of Bringer's lactate. Cycle the NIBP at 1 minute cycles, at least until the baby's out. We miss hypertension because of this. They're all supposed to get 40% face mask oxygen. Now, often this is disputed. The reason that if you ask pediatricians, they'll tell you that we don't give oxygen to the mothers because of some of the effects that the baby may see. And this is true in academic centers. It's true where you've got a specialist anesthetist or a DA anesthetist in the room. But the reason we give 40% face mask oxygen is that if the mother has a high spinal or needs rapid conversion, you've got twice as long to get the tube in. And that's the reason that that's advised. It's for the mother. And the benefits to mom outweigh the very, very academic concerns about the baby. So we're still advising this. We think that you should give the mother 40% oxygen because of the complications that may arise. Once your spinal's in, run the other 500 mils in. Try to get that whole liter in by the time the baby's out, and you'll see much less hypertension. Get the spinal dose right. That's 1.8 mils plus 0.2. It's probably going to change to 2 mils plus 0.2 in the new ESMO-E that's currently being drafted. Wedge your patients. This is, funnily enough, controversial, but because some people feel that this is not required anymore, we're still advising it because about 1 in 10 patients will have hypertension if you don't wedge them, and it'll be uncorrectable with anything you do until you wedge them. If you're finding the surgery is too difficult, wedge them after you put the spinal in, 15 degrees of tilt, and then just before they start, if they want to, you straighten the patient out for the few minutes it takes to get the baby out. If the patient becomes hypotensive when you remove that wedge, you've got to go back in. And really what we're mainly concerned about is that 20 minutes from when you put a spinal in to when you start cutting. Check the block before you start. We're going to be releasing guidelines about this in the next few months, but blocks that aren't working, you don't want to manage a partial block once you've already started cutting. A completely failed block, you may repeat the spinal after 20 to 30 minutes of no effect whatsoever. But a partial block you can't repeat. You either have to wait 6 hours or you need to convert to GA depending on the indication. And finally, get the oxytocin dose right. The dose is 2.5 to 3 units as a bolus after the baby's delivered, and the rest of the AMP, the 7 to 7.5 into the liter that you're now giving as your second liter as an infusion. Don't give 10 units as a bolus. The hypotension you can see with that bolus sometimes causes cardiac arrest. Expect common complications. We see hypertension. Commonly, this is from our unit. 1 in 2 will drop their blood pressures below 100, and 1 in 5 below 80. There is a 20% incidence of severe spinal hypertension. Expect it. And the treatment really is that you must have an incredibly low threshold. What will happen is you're going to put the spinal in, the heart rate will go up, the blood pressure will go down. That's from pharmacological vasodilation. So give pharmacological vasoconstriction. The treatment of of that vasodilation is a vasopressor. And it actually is less relevant which one you choose. Ephedrine, phenylephrine, metaraminol, ethylephrine, whichever one you've got. We've usually got ephedrine or phenyl. Just give it. If you're not sure, give it. And then consider fluids. Could you be behind? So the treatment is generally fluids and vasopressor, but don't forget the vasopressor. We don't review cases where someone gave vasopressor that they shouldn't have. We review cases where people have been too late to act. And really the take-home message for this is that if you're not sure, give it. If the heart rate goes up, give it. If the blood pressure goes down, give it. If the patient gets nauseous, the cause of the nausea is a low blood pressure, give the vasopressor. And if she looks confused, if she starts to act a bit funny, give the vasopressor. I just have a very, very low threshold for treatment. The only proviso is that you must have diluted your phenylephrine. It's a 10 milligram, 200 mils. And then you can give it. Don't obviously give the amp. If you're giving the right dose, you really can't do much harm by giving it. The next thing is that when you see hypotension, it doesn't necessarily mean it's a high spinal. Whenever someone dies of hypotension, people call it a high spinal, but a high spinal is a very specific thing. There's a guideline out on this, which is a free download if you look for it. Generally, hypotension plus bradycardia, that's when you must start to worry about high spinals. And then the level will go up. You'll see people, their hands will start to pill roll, the spinal, they'll actually feel like they can't breathe. And then the treatment is vasopressor, very, very quickly, and support of the airway. And you don't need to rush to intubate them, you need to rush to get the vasopressor in. The heart rate's slow, that treatment is ephedrine or it's adrenaline. And if you're an extremist, you give boluses you put 1 amp of adrenaline to 10 mils and you give 1 to 2 mils. And you need to move quickly. I'm not going to get into phenylephrine infusions because I think that's sort of detailed. If you want to hear about it, we've written this article where we made suggestions. And then this international consensus statement on the management of hypertension with vasopressors has got all the recipes for different settings. And really, you need to tailor what you're doing to your context. So if you, in this context, which is first world sort of high-income country, you're going to individualize management. You're going to give the right fluid for the patient. You're not just going to give a bolus no matter what. You're going to give a slightly higher dose of a spinal, and you're going to run a titrated phenylephrine infusion at that rate. If you're at Edendale Hospital, you'll do similar things, but you'll run a fixed rate infusion, a low dose fixed rate infusion. And if you're in the district hospitals, this is a recipe that we use. We sometimes take 500 mics of phenylephrine and we just put it into that first liter once the spinal's in. And it's a very nice way to keep hypertension away. The worry is that you start to use phenylephrine when the patient's bleeding. And phenylephrine is specifically to counteract spinal anesthesia. So I've got lots of literature on that and I've got lots to say on that issue. And we can talk about it outside this meeting if you're interested. Just a couple of final points. Please value the recovery period. I was always in a rush to finish the Seizures and get these patients to the ward so I could get on with the clinic or whatever was coming next. But this is where we pick up a lot of the problems. This is what's in the ESMO-E guideline. If I can just say, don't rush this period. Take high heart rates in recovery very seriously and low blood pressures very seriously. Don't rush the patient out because once you send them out, they're essentially going to an unmonitored situation or a situation where they're getting BPs every 4 hours. And so many of our reviews at the confidential inquiry are tachycardic, slightly hypotensive patients who go out and then are actually bleeding in recovery. So your patient mustn't go out on a phenyl infusion. They mustn't go out on oxygen unless you've got a specific understanding of what's wrong. And if you're sending those borderline patients out, make sure you review them in the ward. Just walk past them in the next half an hour and make sure they've settled. And then really my final point is that you need to develop friends with anaesthetists in the center that you refer to. That's the ideal. You can phone them and talk to them. Hopefully they'll help you out. If you can't find a friend, then I will be your friend. Just phone me. The only problem is I may not answer my phone. I don't keep it on every night, but you are welcome to try. And if I can't help you, sorry, I have a backup. please use my email address. So when something goes wrong in anesthetics and you think, I wonder what that was, or did we do the right thing? Send me the story and I'll write you what I think could have happened, should have happened, what you could have done. I'll send you literature if you're interested. Please take down my address and really overwhelm me with questions and comments and things you're wondering about. If you're not sure if you should be doing these cases or you're struggling with your referral centers, I can definitely help in KZN. I may be able to help elsewhere, but please use me if you can. And then I'm also available on Vula. You just
Hi, good on you, man. I just wanted to get the front 30.
Dr. Rapuli,
And
could you please mute your mic? Thank you. I'm available on Vula, so if you refer a patient to me specifically at Edendale Hospital, you can refer a patient with all the details and we'll have a chat on Vula. It doesn't mean I'm going to accept the patient at Edendale, obviously. You're welcome to try on Vula, and it's a mechanism we'd like to start developing as a way to reach anaesthetists. And then finally, there are lots of resources that you can use. This is the top one is a Maritzburg video on how to do an obstetric spinal, and it'll about a 12-minute video, and it'll talk you through exactly the procedure that you must follow when you put in a spinal. And the second one is a talk that Simon Leroux gave on exactly the same topic over an hour and with a lot more depth in some of the issues. You can go and find that online as well. If you Google these things, you'll find them quite easily on YouTube. And there are more and more resources coming out like this, and we're going to start recording these lectures and making them available for everyone. And I'm very happy to share literature and ideas around this topic. If you just hold me an email. Right, I'm going to stop sharing my screen now and put my video on.